Well, good morning, everyone. Really great to be here, and really want to congratulate Runsi and everyone for putting together this wonderful meeting. Let me just make sure the slides work. Here we go. Could you go to the Lionel to the very beginning, please? You know, it's been a few years since I had a chance to talk about the Moonshot, so I thought I'd share with you what all we've done over the last 10 years or so that since we started this program. These are my disclosures before I start. But one of the first programs that we put into place related to personalized surgical care. And I'll show you some updates from that in terms of what we've been able to accomplish. And then also, some observations that I've had ever since I was in training about how ovarian cancer appears, and in terms of its visual appearance and what impact that could have. And then also about some of the new treatment approaches that we've been working on over the last few years. You know, when I talk about the Moonshot, this was a vision that our prior president, Dr. DePino, had in terms of making major advances in ovarian cancer. You know, the term Moonshot actually is not new in the context of cancer. I don't know how many of you know who this woman is. Her name is Mary Lasker, and she was one of the biggest champions for cancer research through the 1950s and 1960s. She's actually the one who used the term Moonshot for cancer initially, and that's what she wanted to propose in the 1960s. At that point, you know, there was already a moonshot for going to the moon that was going to take place. And so the Nixon administration didn't really want to use the word moonshot, so they ended up calling the war on cancer. And there was a lot of sort of militant words that those were used for a variety of things in those days. But the reason I wanted to show you her picture is that she has a really famous quote that I really love, that if you think research is expensive, try disease. And such a profound statement, you know, in terms of why research is so important for having an impact on ovarian as well as so many other cancers. But I just wanted to share with you that this term, Moonshot for cancer, is not a new term. It's been around for a long time, and the credit should really go to Mary Lasker, who first thought of this term. Now, I had a chance to be involved in a national panel for ovarian cancer research and state of the science in terms of what was being done. And we put together this figure that I think is really informative, which looks at, you know, a lot of people will show you the statistics in terms of how many patients are diagnosed and so on. But the reason research is so important for this cancer is something called death to incidence ratio for ovarian cancer. And if you look across many other cancer types that are more prevalent in terms of comparing to breast cancer and so on, ovarian cancer has among the highest death to incidence ratios. And if we look at some of the more recent data, so this is mortality to an incidence ratio, which is similar to the death to incidence ratio. A group in Australia put this together, and if you look at breast cancer over the last several decades, you know, the mortality to incidence ratio, which is defined as number of deaths in a given year divided by the number of newly diagnosed cases, it actually has come down quite a lot. But if you look for ovarian cancer, the death to incidence ratio it hasn't changed a whole lot. So that doesn't mean that we haven't made progress. And I will end with a final slide to show you what kind of progress we've made. But what we really want to achieve is more cure rates as well as improving survival. Okay. Now, our charge was, when we started the Moonshot program, is, you know, number one, how do you make advances based on the current state of knowledge? And our charge was that we had to improve patient outcomes by at least 30% within a 5-year period, which is an incredibly aggressive goal for a cancer like ovarian cancer that continues to have a lot of challenges with it. So when we first started, we organized the whole program around 3 things: improving upfront therapy, coming up with new treatments for relapsed ovarian cancer, and then a rare subtype of ovarian cancer. I think you've heard talks on this related to low-grade serous ovarian cancer. All of these areas have had major advances in the last 10 years or so. Our current focus is on, for the next year, is on 3 areas. And I'm going to show you some examples for targeting tumor metabolism in terms of how we're thinking about that for new treatments. And then also this area I won't talk about, but there are concerns about secondary cancer, such as leukemias developing in patients who are treated, especially with PARP inhibitors and so on. And then finally, some of the immune therapies. Again, you've heard some talks around this. Today, I won't address that part as much. Now, when Dr. Nick was working with us, who just came in, she actually helped us put together this data. And, I had known this ever since training, that if we operate on patients with a suspected advanced ovarian cancer, and if we operate with a large incision, it's only about 1/3 of the times at most that we could remove all visible cancer. And that always bothered me. That meant that, we need better or more personalized approaches so that we're smarter about who we're operating on, where we can maximize the chances of removing all cancer, or come up with an alternative strategy up front and then operate a bit later in time. So again, remember this statistic, though, that at best, it was about 1/3 of the times that we could remove all cancer before the program I'm going to show you, that we could remove all visible cancer. So, we looked at, okay, well, what do you do about it? If we look at a lot of the other things, such as circulating markers, they're not so good at predicting when we can or cannot remove all visible cancer. CAT scans, PET scans, MR scans, none of those are able to predict when we can or cannot remove all visible cancer. So after thinking through it and planning a lot, and Dr. Nick actually helped us put together retreats over about a 6-month period, we focused on laparoscopic assessment. So laparoscopy, I think you've heard talks on this before. We use a couple of ports, tiny ports, to look inside the belly to see multiple areas, and each area is given a score. And I'll talk to you more about this. So this is the program where now women with suspected advanced ovarian cancer who can undergo surgery, who are considered surgical candidates, they undergo this laparoscopic assessment. Then we look at 7 different areas within the belly and pelvis. Each area is given a score of 0 or 2. And then we add all of those up. If the score was less than 8, then we felt that, okay, it's appropriate to move forward with surgery. And in that setting, over the last 10 years, the likelihood that we can resect or remove all cancer surgically approaches 90%, okay, which is a lot different than the 30% if you operate on everyone with a big incision. Moreover, if the score is high, where surgery cannot be done, where you can't remove all visible cancer, even in experienced hands, meaning GYN oncologists who are doing the surgery, then we start off by giving 3 to 4 cycles of chemotherapy and then operating after that. And the likelihood that we can remove all visible cancer, we term that R0, is about 3/4 of the times we can achieve that. So that's a lot different than what we were doing in the past. Now, does this make are there differences in these patients? So Dr. Fleming, Dr. Nick, based on the first 3 years of data, the dark line here, so this is called progression-free survival. So this is following patients out to a point in time where their cancer either comes back or grows further, okay? So the progression-free survival for those patients who have complete removal of surgery up front is a lot better than patients where we end up having to give chemotherapy up front and then achieving all cancer or removing all cancer. Unfortunately, the worst outcomes are when we cannot remove cancer even after giving 3 to 4 cycles of chemotherapy. We have a lot of work cut out in that group of patients particularly, and it likely reflects particularly aggressive disease in those patients. the overall survival for these patients wasn't mature until recently, and over the next year we will be reporting that as well. But it really is it emphasizes the importance of having this kind of a systematic approach for taking care of patients. Now, one of the things we worried about initially was that, is this cost effective? And does this, can this work? And we also worried about, will insurance companies pay for the laparoscopy and so on? Not only is it cost effective, based on a study from the Netherlands, but our own data from MD Anderson also shows that this is an entirely cost effective approach. And if anything, you avoid doing futile laparotomies, meaning the big surgeries where you cannot remove all visible cancer. Again, remember, those are not benign surgeries. They can have real risks and complications and so on. We think that this is certainly a lot smarter way of providing care, or much more personalized care for patients with suspected advanced ovarian cancer. Now, I'm just going to show you some observations that, as I had mentioned earlier, ever since I was a trainee, I kept looking at the different appearances of cancer, and there's certainly a lot of different patterns, but we never had a way of categorizing that, nor did we know that does it matter. Now, if you look under the microscope, these are both high-grade serous cancers from two different patients. They look identical, okay? And I try not to put too many surgical pictures for a variety of reasons, but in this setting, I feel like I had to just show you a couple of examples, so bear with me, okay? Now, if you look at these two patterns, this is both looking at the diaphragm, so the muscle that helps you breathe, looking at the diaphragm. On the left-hand side, this cancer in this patient looks a lot more infiltrative. That's kind of attached and eroding into the diaphragm lining itself. Whereas on the right-hand side, this is much more what we call exophytic, where the cancer is just kind of projecting out, and you can peel this off relatively easily, okay? There are lots of these kind of pictures. I'm just going to show you a couple of these representative images. And so we recorded all those videos through the laparoscopy, so we had the ability to go back and look at, do these visual appearances make a difference? And we actually developed a scoring system where, for just simplicity purposes, we just call it type 1 or type 2, where type 1 is that more of a left-hand side picture where the appearance is much more infiltrative all across the patient's abdomen and pelvis. And on the type 2 is that much more superficial exophytic appearance. I'm just going to show you a couple of slides around this, that how this can be meaningful. If during the surgery, the blood loss, for example, in the type 2 appearance cancers was a lot greater. So there are differences, even clinically. We do have some differences even in patient outcomes and so on. I'm not going to go into that in as much detail, but I wanted to just show you one other aspect. And this is just a alphabet gamish, but the whole point about this slide is that the type 1 and type 2, if we look at the genetic makeup of these cancers, are not the same at all. There are major differences in the genetic makeup, and that likely dictates how these cancers behave and the way they invade or infiltrate or not invade, et cetera, into the different surfaces. We think that this kind of work may inform how we can approach, or what other drugs we might be able to combine with chemotherapy, but this is a very early start. We're actually also now looking at using artificial intelligence based on all those videos to figure out if that kind of a system can categorize the different patterns much more objectively. Okay? So this is just ongoing work, but I wanted to just share some of that with you as well. So for the first part, we think that laparoscopic assessment remains a cost-effective approach for personalized surgical care. This has been the standard of care at MD Anderson for 10 plus years now. We've taken care of over 1,400 women with that kind of an algorithm now, and many other centers have adopted that kind of a personalized approach now. We think that there are extensive molecular and cellular differences even within the same subtype of ovarian cancer, which is the high-grade serous, that we feel is incredibly important to understand as we move forward. Now, the Moonshot program is not a static program. I wanted to show you that over the last 10 years, these are many of the projects that we started. Many of these became routine standard of care approaches. So they, quote, graduated from the Moonshot because that's just how we do things. For example, when we first started, the germline or the genetic testing rates were about 20% or less throughout the country. At MD Anderson, they were about 40%. Okay, within 1 year, we exceeded 80%. So this program lasted for about a bit over 3 years. Now that's a standard of care. Every patient who is diagnosed with ovarian cancer is offered genetic testing. And if they agree to have it, then we move forward accordingly. Again, I won't read all of these, but this has been an incredibly impactful program. There have been drugs that have been FDA approved that two have been also listed on NCCN guidelines based on our work in the Moonshot program. So it's been incredibly impactful for changing practice for patients with ovarian cancer. Now, in the last half, I'll just share some work, again, that's ongoing with new drugs. Rinzi had asked me to talk a bit about how we're thinking about some of the targeted therapies and so on. It's an incredibly active area. So I'm going to focus on a specific area for today's purposes. And just to show you a snapshot, this is the first about, since the 1960s or so, leading up to about 2013, 9 FDA drug approvals that were all chemotherapy based. Since then, this slide is so busy on the right-hand side, I couldn't even fit all of them. There have been 15 plus drug approvals since 2014. So a lot of progress in that. It is clinically impactful, but we still have a lot more work to do moving forward. Now, the area that I'm going to focus on is an area that I've been working in for about 25 years, which relates to targeting the blood supply to cancer. So for a cancer that's forming, as shown in these green cells, for it to grow and get bigger and spread, it has to recruit blood vessels, and that process is called angiogenesis. Okay, Judah Folkman first really conceptualized this whole process around in the early 1970s. For patients with ovarian cancer, a drug called bevacizumab, which is an antibody that targets a growth factor called VEGF, led to 3 FDA approvals for upfront maintenance for patients with platinum-resistant disease and even for patients with platinum-sensitive relapsed ovarian cancer. Now, so those clinical trials that led to FDA approvals are boxed in these blue boxes. The challenge, though, is that despite this treatment, this is not a curative treatment. Most patients will develop resistance, or their tumors will develop resistance to these drugs. And that I call adaptive resistance, meaning despite the drug, those cancers will start to grow at some point. This is one of my patients I took care of a few years ago, where we started this bevacizumab-based treatment. And this is a CA-125 plot, a beautiful response initially that lasted for several weeks. But then after that, the cancer starts to grow again. So the question that we asked is, what gives? Why is it that the cancer starts to grow? And we've created these animal models where we keep treating with the drug where the cancer starts to grow despite treatment. And one of the things we learned is that as cancers start to regrow, they have 2 cell types that infiltrate the tumor within the tumor that are type of immune cells and these immune cells are not the good type of immune cells. Okay, these are called tumor-associated macrophages, or something called MDSCs, or these myeloid suppressor cells. They heavily re-infiltrate in the tumor and promote tumor growth despite the VEGF drug. Now, we did a lot of preclinical work to understand that, and we think that that targeting macrophages is actually feasible. This is our pilot trial that we just finished now, where patients were given either the paclitaxel plus bevacizumab, or adding in a new drug to target the macrophages. This is meant to help us understand how the tumors adapt. So there were biopsies that were built in pre-treatment and after treatment, and those are now undergoing analyses. But we really feel that these kind of studies are so important, and without patients who agree to have these kind of biopsies, we can't really understand the biology in these tumors at all. So that trial is finished, and there's another trial also targeting macrophages that is well underway. A second pathway that we've been very interested in is called the DLL4 Notch pathway. And I'm sorry about all these weird terms, but DLL4 stands for delta-like ligand 4. Through our and other studies, we figured out that it plays a really important role for blocking the effectiveness of drugs like bevacizumab. So this is a tumor where the bevacizumab itself doesn't really work well, but if you target DLL4 as well, you can actually shrink tumor growth quite well, okay? So based on this, we did some, again, animal work first before we bring it to humans, and lots of controls here, but the two I'll just call your attention to are where we target DLL4 plus VEGF plus a chemotherapy drug, an incredible effectiveness that we saw in these mouse models. We were very excited about this combination and then brought this into clinical trials. One of our colleagues actually helped us develop what's called a bispecific antibodies, meaning it's got two arms to it. One part targets that one growth factor VEGF, and the other part targets the DLL4. So with a single drug, you can block two given growth factors of interest. This was first brought at MD Anderson into phase 1 trial, and then since that met its endpoint, it was brought into an expansion phase for a clinical trial. Really incredible data. This was reported just a few months ago. The objective response rate approached 44%. We've never seen those kind of responses in this kind of a patient population who have recurrent relapsed ovarian cancer that's platinum resistant. We're quite excited about this particular drug combination. The FDA, by the way, granted it a fast track designation because it was such an active combination. Now, this particular bispecific antibody, they're trying to raise funds to bring this into further clinical trials to then eventually seek the full FDA approval that would be needed and so on. But it's certainly a very active combination. The final example I'll share with you, again, came out of work through the Moonshot, which is targeting metabolism. It's just a simple analogy for metabolism because it can mean a lot of things. So for our bodies, metabolism basically means you consume energy you consume these foods and so on to generate energy, such as ATP, that helps you generate heat, it helps you function, it helps you exercise, whatever that may be. In the context of cancer metabolism is a process by which cancer cells can obtain energy that they need to divide faster and grow and spread and so on. Now, cancers are unlike the many other parts of the body. They can hijack the other parts of the body in terms of getting the nutrients they need to be able to grow and so on. This is an incredibly complex slide, and I only want to mainly point out to you that as tumors became resistant to that same class of drugs, the bevacizumab drug, one of the dominant pathways in metabolism that we found is something called a purine metabolism, particularly a metabolite called glutamate that the tumors can then use to grow, and despite the VEGF-targeted drug. Now, at MD Anderson, there was a drug called IX6274 that was developed about 3 years ago that targets that particular metabolite, so that it blocks the generation of that metabolite. So we brought this into animal studies, and again, this is that resistance model. This is a neat way to look at metabolism because you can look at it on a single slide. Where you see red, that means there are high levels of a given metabolite of interest, and where you see darker colors, that's a quieter area. This is a really neat way of looking at this metabolism pathway. So here's that glutamate pathway. We found that when tumors are sensitive, that glutamate metabolism is relatively low, but when they're resistant, it's quite high. So what can we do about it? Well, We brought this into further studies, and we added this glutaminase inhibitor along with bevacizumab and saw fairly striking activity in terms of blocking or reducing tumor growth. Importantly, we saw that when you do this, that the metabolite of interest, glutamate, is entirely reduced by that glutaminase inhibitor. So again, it's another way of targeting ovarian cancer in combination with an anti-angiogenesis drug to improve its effectiveness. Based on this preclinical data, this is the current clinical trial that's active, where we use that IX6274 to block tumor metabolism in combination with bevacizumab as well as paclitaxel. The first cohort of patients has already accrued. Now we have to wait about 4 to 6 weeks to make sure that there aren't any untoward activity, side effects and so on. But so far, really encouraged by the activity that we're seeing with this particular combination. So we're very excited to move this forward. So this final summary then is that obviously there are a lot of adaptive changes occur, with the pressure that we put on with bevacizumab drug. But each of these adaptive changes is an opportunity for new drug development and for prolonging the effectiveness of this kind of a drug. And I shared the different results with you related to macrophages, DLL4, as well as blocking tumor metabolism. Now, I continue to track this data annually, and I've shared this kind of a slide with you a few years ago. But if we look at, are we making a difference? Are we really changing the trajectory of what patients go through? So the answer is yes. The incidence of ovarian cancer has actually declined by almost 30% in the last 20 years. Now, if we look at mortality, that's come down by about 27%. And prevalence meaning that those women, those patients who were diagnosed with ovarian cancer and either cured of ovarian cancer or who are living with ovarian cancer, that number continues to go up year over year, and that's increased by almost 40%. Okay, so yes, we haven't improved cure rates yet, but we clearly have improved the progression-free survival as well as reduced mortality and so on, and that I think forms a good basis for ongoing work to even have broader impact. All right, with that, I'll finish. Thank you again for inviting me. I love this slide that we took at Kaylee's run a few years ago. And she's such a champion for the beach symptoms and so on as well. Thank you again.